Hi everybody who's joining this seminar right now. So thanks for joining today. We're just going to wait a couple of minutes longer for others to join. Okay, so I think it's probably time to get going. I can see the amount of people who've joined has sort of stabilized now. So this is the first in a series of seminars, which will be given by each program within the Social and Public Health Sciences unit. And that's in addition to the previous seminar by Petra Meyer, who introduced a new work stream in Glasgow, and the CIPHER Consortium. So today's seminar will be introduced by Alistair Leyland, with multiple presenters from the program talking about the research on COVID within the Inequalities program. So we're going to have multiple presenters today who are going to share their screens. So please just let us know if there are any technical issues that arise as we move through. You can add it to the comments box at the bottom and we'll all be able to see that. We should also have time for a short question and answer session at the end. And you can either put your hand up and ask your questions verbally. I'll just unmute you, or you can add them as we move along to the question and answer bar. And that's quite nice as well, because it'll give us all time to think about how we answer that. So while the presenters aren't presenting, if you just turn off your screen, and then you won't be a stop video, and then you won't be a distraction in the corner. And I'm now going to turn off my screen and pass over to Alistair Leyland, who will introduce today's session, give a brief overview of its structure and also the Inequalities program. Thank you.
Great, thanks very much, John. Yes, we'll get on to the 4 presentations soon, but I just thought I'd give a brief overview of the wider research on COVID-19 going on within the program. The Inequalities in Health program has the aim of improving our understanding of inequalities in health. It's co-led by Peter Craig and me. We have 4 closely linked work streams on measuring inequalities, understanding inequalities, reducing inequalities, and inequalities in the workplace. COVID-19, to date, we've got a number of papers published, some of these with colleagues across the Institute. You can find all these, as with most of what I'm talking about, on the unit's excellent COVID-19 webpage. We have been repurposing research funding to look into COVID-19. We didn't have the foresight to include it within our QQR funding bid. So there are 4 projects listed here. We have, in addition, the 4 projects we'll be talking about later. My apologies to those whose work I've missed here. We also have funding proposals. Vital has succeeded in getting funding from the UKRI and NIHR, but we have further applications in process with the Health Foundation and UKRI COVID-19 call. Other outputs, we've got a wide range. Of course, we do have colleagues who've returned to clinical work, and Vital's been contributing to the Scottish SAGE. We've got a few of us have been working with Public Health Scotland. We've given feedback on consultations, blogs, editorials, conversation pieces, discussions, and of course our latest offering, the podcasts, 15 Minutes on Health Inequalities, which have 2 podcasts on COVID-19. Upcoming, so this month we have 3 further presentations from the programme, from Vital next week at the Society for Social Medicine plenary. If you haven't registered for that yet, you have until tomorrow to do so. Ruth is presenting at the second FINS webinar week on Thursday, and then Vital and Claire are giving another one of these unit seminars in Leah and Vital, who are going to be talking about some of the work they've been doing, which is in different stages of completeness, but I'll leave it to them to tell you all about that. So thanks very much, and Peter, over to you.
Okay, thank you very much, and sorry for that delay while I faffed about choosing the right screen to share. So I first introduced this study at the unit conference about 10 weeks ago, but 10 weeks is a long time, even during a pandemic. So I'll give you a brief reintroduction to the purpose of the study and the methods we're using, and the background in terms of what's known already about the effects of school closures on inequalities, and then present some of the results that we've recently pulled together. So the background, the main item in the background, of course, is that school closures are one of the most widespread responses to the global pandemic that governments implemented. They were implemented around the world. They affected 1.5 billion children at the height of the pandemic in early April. Almost every country in the world implemented school closures as part of their lockdown measures. And as I said when I first introduced this study, you would think, given the scale of this response and the breadth of this response, that there'd be strong evidence that school closures are an important component in controlling the spread of infection during a pandemic. In fact, the evidence is remarkably weak on that point. Systematic reviews of earlier pandemics and modelling studies during the current pandemic suggest that the effects of school closures on reducing the spread of infection is actually quite small. Which puts the spotlight back onto what the effects of school closures might be on outcomes other than rates of infection. And there's been very high level of concern about the effects of school closures in the UK on children's learning, and in particular on inequalities in children's learning. And there's been a whole series of surveys and other pieces of work conducted by academics and by NGOs to look at these questions. And the idea that school shutdowns drive widening inequalities has become very influential. You may have seen reports of surveys this week which suggest that school closures may have widened inequalities by 46% during the lockdown, a figure derived from this study by the National Foundation for Education Research. But as I was saying, the extent to which we have hard evidence of the effects of school closures on children's learning, as well as on the spread of infection, is not that strong. As well as the contemporary concerns, there's been a long-standing concern about what the effects of routine school closures are on children's learning, and the effects of summer holidays. A lot of this interest stems from a seminal study that was conducted in the US back in 1990, which suggested a large proportion of total inequalities in children's learning between more and less affluent children was attributable to school closures. However, this result has not been replicated in more recent studies. It's quite a common feature of the evolution of an evidence base in public health as a kind of regression from an initial eye-catching finding of a large effect down to a much smaller effect. And that's what's happened with the idea that school closures during the summer affect children's learning in a way that widens inequalities. And recent studies haven't tended to replicate this early striking finding that school closures account for a large proportion of total inequalities in learning between more or less affluent children. So where does our study come in? We tried to do two things. The first was to do a scoping review of the existing evidence to see just how strong the evidence is to base assumptions of the effects of school closures on. We looked at English language studies published around the world since 1994. That was the last date at which studies were included in a previous systematic review. We looked at studies that examine gains or losses in cognitive development or in emotional well-being over the summer holidays. And we coupled this with a secondary analysis of the Millennium Cohort study. We look at differences in cognitive ability and mental well-being between children according to their mother's education and household income. And we use the fact that fieldwork in the Millennium Cohort study is spread throughout the year to make comparisons between scores assessed during interviews conducted in the months before the school holidays with scores on the same assessments conducted after the school holidays. And we do this for 3 waves of the Millennium Cohort study when the children were aged 7, 11 and 14. So I'll briefly describe what we found in each of these 2 studies now. So the scoping review, it was done very systematically. We looked at 4 databases. We found over 3,000 titles to begin with. We excluded 2,900 on the basis of titles and abstracts, another 100 or so on the basis of the full text, which left us with 28 articles covering 26 studies. Most of these studies came from the US, a few from Canada, New Zealand, and Europe. Most of them focused on reading as the main outcome. A few also looked at maths or science. None of them looked at well-being. Most of the studies focus on younger children who are either in preschool or in the early years of primary school, and they examine differences by a wide range of markers of social position. And the findings are largely inconclusive. Most studies report no widening of differentials, or they report inconsistent findings across the different comparisons or outcomes used in the study. In the few studies that do report changing differentials, widening or narrowing inequalities, the direction tends to vary, with some studies reporting changes that favor disadvantaged students. So there's no consistent picture emerging from all this research that inequalities naturally widen or generally widen during summer holidays. Another feature of this literature is that there are persistent concerns about study methodology. It's not a straightforward matter to examine changes in inequalities, and the way the assessments used operate can have a strong effect on the findings that emerge. A way of measuring attainment that's better at differentiating between more and less able students will tend to indicate widening inequalities. One that's less good at differentiating will tend to indicate less wide inequalities. So the study used different tests at different times, and it's difficult to interpret changes in inequalities and difficult to link them back to underlying changes in inequalities in learning outcomes. So a rather inconclusive picture from previous studies. So the next part of our study was this secondary analysis, the Millennium Cohort study. This, as far as we know, is the first study to look at UK data. The Millennium Cohort study, as most of you will know, is one of the series of UK birth cohort studies. It's a a nationally representative survey of children who were born in the UK between 2000 and January 2002. And we analysed data for children when they were aged 8, 11 or 14. The outcome measures we looked at emotional well-being using the Strengths and Difficulties questionnaire, and we looked at cognitive ability using the literacy measures that were used in the 3 waves of the survey. There were different measures used in each of the 3 waves, but within each wave, all the children were assessed using the same measures. We don't have to worry about the differing performance of differing methods of assessment in the context of our study. To measure socioeconomic status, we focused primarily on mothers' highest educational level, divided into 3 from degree at the highest level to GCSE or lower at the lowest level. And we analysed the data using regression models to compare outcomes for children who were in more or less disadvantaged households before and after the school holidays. And so these are the key findings. I've concentrated on the findings on the reading and SDQ well-being scores. We also looked at the pro-social scores on the SDQ. I haven't presented those here, but I'll briefly refer to them later. So what did we find? Well, we found, as you might expect, if you look at the first 3 rows of the table, starting on the left-hand side, that children's reading scores vary widely according to mother's education, with much lower scores amongst children with mothers in the lowest educated category. I should point out here that because the different ways of the survey use different reading assessments, we can't interpret the differences in the scores in the left-hand column in terms of a converging of performance because the tests were rather different in each case. But in each wave of the survey, we find that mother's education is associated with, or lower mother's education is associated with lower scores. If we move rightwards and look at the effects of school holidays, we find that age 7 and 11, well, at age 7 at least, scores are lower after the school holidays, less effect when children are aged 11 and 14. And if you look at the final column, we see that there is no significant interaction between school holidays and mother's education. In other words, the performance of the children from the least educated with the least educated mothers didn't get worse relative to the performance of the children from higher educated mothers over the school holidays. So no effect there. We move on to the SDQ scores. Again, we find that there's a raised risk of poor mental well-being amongst children whose mothers had lower education. That's the first column. Raised odds of 5 or around 3 amongst the older children. But again, when we move on to look at the school holidays, we find much less evidence of an effect, possibly a marginal effect in terms of school holidays raising poor mental health amongst the children from the least educated mothers. But when we look on at the interactions, we find no significant interaction between school holidays and mother's education. In other words, we don't see any widening of inequalities over the school holidays. I should draw attention to a couple of strengths and weaknesses. As I said, our study is the first to use UK data. And unlike some of the earlier studies, we were able to use the same measures of ability for children assessed before and after the school holidays. And unlike most previous studies, we looked at mental well-being as well as cognitive ability. A few limitations. Ours was a scoping review, not a systematic review. We didn't do a full critical appraisal of all the included studies, but we were able to take this broader approach than previous reviews. The Millennium Cohort study is not designed to be analysed in the way that we did. The samples drawn in each month are not representative of the UK population, or the UK population of children. So we needed to carefully adjust for that using inverse probability weights. And then the final key point, I think, is that school closures that were conducted during the pandemic are not the same as school holidays. the curriculum carried on to some extent in many schools, but holidays and closures are similar in the sense that children from more or less disadvantaged households will tend to have widely differing experiences during the period of closure. So what are the implications of this? Well, the main conclusion is that school holidays don't widen inequalities in reading ability or in mental well-being amongst UK children. Having said that, we should acknowledge that COVID-19 related closures may have had larger effects on differentials because they lasted longer, because differences in support for learning were probably wider during the lockdown than they are during summer holidays in general, and also possibly because disadvantaged children tend to live in households that were more severely affected by the social and economic disruption, the job losses and income losses and so forth during the pandemic. And these effects should be an important focus for future research and monitoring. Many thanks.
Is it me next? Yeah. So I'm just sharing my screen. Oh, there we go. Okay, so I'm going to be talking about older people and loneliness in COVID-19, and I wanted to start just first of all by distinguishing social contact, so kind of contact with other people, from loneliness, which is more of kind of a perceived feeling of social isolation. So a person might feel lonely even though they experience frequent social contacts with other people, or they might not feel lonely even though they have very few contacts with other people. They might just not feel like they need it. Nevertheless, social context is quite closely associated with less depression and less loneliness. And so why might that be relevant in the current situation? Well, we've got this pandemic and lockdown, which the lockdown, one of the main purposes of it is to heavily reduce kind of in-person social contact. And that reduces the risk of infection spreading, and that's a good thing. But it may also, in terms of reducing that kind of person-to-person contact, may kind of isolate us and increase our risk for loneliness or depression. And in terms of older adults, they've been identified as especially vulnerable to COVID-19, and many have been advised to be shielding because they've got underlying health conditions, and so they will be kind of especially avoiding contact, and therefore might be especially at risk of kind of being isolated and lonely, depressed, etc. We're also probably by now familiar with the concept of physical, not social distancing. So even if we are not physically present with each other, we might still have social contact with other people using kind of remote means of contact. That'll be things like phone and internet. They'll kind of become especially salient as we're kind of physically distanced from each other. And when people talk about concerns about the isolating impacts of lockdown on older adults, one of the first kind of recommendations often made is to talk about kind of increasing or maintaining kind of remote social contacts with older adults. And what does any of this have to do with inequalities? Well, loneliness and depression are more common, and social contact is less common among older adults who live alone and who have a disadvantaged socioeconomic background. So the changes that we see in social contact, for example, due to lockdown, could have a couple of different effects on inequalities. So they could potentially narrow inequalities by reducing the social patterning of a salutary factor. So social contact is beneficial. And so if you reduce it to kind of a low level for everybody, then you kind of potentially remove the privilege of those who are more advantaged, and that could narrow inequalities. But they could also widen inequalities, and that could be if some people benefit more from contact with others. So if you reduce everybody to kind of the same low level and some benefit more than others, then it could potentially widen inequalities. So the aims of what we were trying to do was just to estimate and compare the effects of in-person versus remote social contact on loneliness and depression. and then try and estimate the impacts on inequalities for two different scenarios. One for everyone getting reduced to less than weekly in-person social contact. So that was just trying to sort of vaguely approximate the impact of lockdown. And then a scenario where everyone receives at least weekly remote social contact. So that's kind of trying to get at if people follow the advice to sort of maintain or increase remote social contact. The data we're using come from the 8th wave of the English longitudinal study of aging. So we just look at in cross-section at the 8th wave. And we had just under 6,000 respondents with complete data. And in initial preliminary analyses, we noticed some interactions with age. So we split the sample into those aged 65 and over and those aged under 65. The outcomes we look at are depression measured using the CESD scale, and then two measures of loneliness, one being kind of just asking if how often people feel lonely, and then a kind of a more formal scale that measures loneliness based on a few different questions. The inequality measures we looked at were education, and then partner status, comparing those who live with a partner versus those who live on their own. Wealth based on kind of the net total non-pension household wealth. And I show comparisons of the lowest quintile versus the highest, but we did look at kind of all the quintiles and there was kind of a similar pattern. And then we look at two kind of different measures of social contact, one being kind of in person, so actually meeting up with children, friends or family, and then the other being kind of remote contact. So how often you have contact like telephone, email, letter or text. We considered a range of confounders, which I'm not going to go into in any detail. And then, so for methods, so to get it kind of estimating the overall effects of in-person and remote social contact, we use inverse probability weighting to estimate the average treatment effect. So that's the average effect of each kind of social contact within the sample. So that's just an average effect and doesn't necessarily account for heterogeneity in the effects of social contact between different groups. And so the way we try to estimate impacts on inequalities does try to account for that. So we use inverse probability weighted marginal structural models to estimate something called a controlled direct effect. So that can be interpreted as the effect of the exposure, such as education, when social context is set to a particular level. Social contact is set to a particular level. And this modeling explicitly allows for an interaction between social contact and the exposure, such as education. So the level that you set social contact to is important. And so we look at the impacts of inequalities if we set in-person social contact to be infrequent for everybody, and on the impact on inequalities if we set remote contact to be frequent for everybody. So these are the estimates we have for effects of both in-person and then remote social contact in the two age groups. So if we look at actually remote social contact first, there was actually no effect on loneliness or depression for remote social contact on average in either age group. Whereas for in-person contact, in both age groups, there seemed to be effects where weekly social contact reduced the risk of loneliness. And then for depression, at least in the higher age group, there seemed to be at least a suggestion of effect, though the confidence interval just kind of barely crosses the null. So now if we look at the kind of inequalities associated with education. So the blue bars show odds ratios, so a confounder adjusted average treatment effect for low education on loneliness and depression in both age groups. So there's a clear kind of significant effect in all age groups for all the outcomes. When we simulate kind of everybody being reduced to less than weekly in-person contact, the magnitude of most of those odds ratios reduces and the confidence intervals cross the null threshold. So that suggests that lockdown could potentially narrow inequalities in education, educational inequalities in these outcomes. In contrast, if we look at kind of trying to raise everybody to receiving weekly remote contact, we compare the green bars to the blue bars, there's almost no difference. So kind of increasing remote contact had almost no difference except for depression in the youngest age group. These are the results looking at inequalities between those who live alone and those who live with a spouse or partner. So for the blue bars, kind of the average treatment effect, there's clear effects on loneliness and depression in both age groups. When we look at increasing everybody to receiving weekly remote contact. The green bars compared to the blue are very similar. So kind of the remote contact has very little impact on the inequalities again. Whereas reducing everybody to kind of infrequent in-person contact, the effect of that on the inequalities differed by age group. So in the younger age group, the magnitude of the odds ratio reduced slightly, whereas for all the outcomes. Whereas in the older age group, the magnitude of the odds ratios increased. So the inequalities were widening in the older age group when we reduced everybody to infrequent in-person contact. And then for wealth, if we focus just on the depression results, because there was actually no kind of clear effect even before we start simulating impacts on social contact for loneliness. But for depression, there was a clear effect in the blue bar in both age groups for being in the least wealthy quintile. And similar to the previous slide, in the younger age group, when we kind of simulate everybody receiving infrequent in-person contact, in the younger age group, the inequality reduces, whereas in the older age group, the inequality gets wider, and remote contact has almost no impact, again, on the inequality. So just to sum up, so if we kind of try and reduce everybody to receiving infrequent in-person contact, then it seems that education inequalities in depression and loneliness could narrow, and inequalities in loneliness and depression by partner status and inequalities in depression by wealth seem to narrow slightly among those aged under 65, but widen among those aged 65 or over. And ensuring that everybody received weekly remote contact had almost no impact on the inequalities. So this kind of suggests that adults aged 65 who are at least wealthy and who live alone are likely to be especially at risk of depression, loneliness during lockdown. And it suggests that remote contact may have limited capacity to mitigate this impact. I'll just quickly summarize a couple of limitations. So we're using cross-sectional data, making assumptions that there's no residual confounding, although we adjusted for quite a range of confounders, and assuming that there's no reverse causation. So for example, that depression doesn't cause people to have less social contact, which is probably quite a strong assumption. We're also only using pre-pandemic data. So there's another strong assumption of consistency, i.e. that social contact has the same effect when impacted by lockdown as it has when we've observed it outside of lockdown. So for example, you might expect that the quality or the frequency of remote contacts may have differed in kind of post-lockdown or during lockdown versus before lockdown. We're also only looking at kind of focusing in on one mechanism of many that might impact on these outcomes and on these inequalities. Others might include, for example, like heightened worries or anxieties about your own or others' health, or anxieties related to the socioeconomic impacts of lockdown on yourself or others. But this is just starting to try and use some pre-pandemic data to get at the mechanisms of how the lockdown might impact on people. But thank you for listening, and special thanks to my co-authors, especially Elise Whitley, who did most of this analysis. So thanks. I'm gonna stop sharing my screen and I'll hand over to the next presenter.
Hope everyone can see my screen. So good afternoon, everyone. Today, I'm gonna present a study that we've recently completed, looking at occupation and risk of severe COVID-19 using UK Biobank data. What do we know so far? We know that essential workers, as well as older adults, are particularly vulnerable to infection and adverse subsequent outcomes. However, up to date, there's only been a few studies globally that have looked at the risk of COVID-19 across different occupational groups and also considered potential confounders. The risks at different occupational groups have varied and have not been equal during the lockdown. And we know that essential workers who provide crucial or fundamental public services, such as those in healthcare, social care, and transportation, for instance, have continued to go into their workplaces and carry out their daily duties. And these essential worker groups have increased exposure to the SARS virus through their work, because it could bring them into close proximity with members of the public or infected patients, particularly since carriers may be asymptomatic. Our preliminary research indicated that occupational exposure to SARS was of great concern, especially at the beginning of the outbreak for healthcare workers in whom the lack of personal protective equipment caused a real and justified fear about their personal safety. And inadequate personal protective equipment and challenges in implementing timely and effective practices have resulted in significant outbreaks in different occupational settings. And one such example have been care homes, for instance. So despite these large occupational differences being seen, there has been a lack of studies examining the risk of COVID. And apart from healthcare workers, it wasn't clear which other occupational groups would be most at risk. So the aim of our study here is to assess the risk of severe COVID in essential workers relative to non-essential workers. We've used linked data from the UK Biobank study and COVID-19 test results from Public Health England to examine severe COVID risk by broad essential occupational groupings. We've broken these down into more detailed essential occupational groups, and we've also analyzed using major groupings as classified by the standard occupational classification system. For this presentation today, I'm only going to focus on the first two, so I'm only going to focus on the results of the broad essential occupational groups and the detailed essential occupational groups. So our study population were UK Biobank participants who were working at baseline, who in March of 2020 would be below retirement age, so below 65 years of age, and they had their baseline assessment in England, as we only had COVID test results for England. The outcome of interest in our study was severe COVID-19. The way that we've defined severe COVID for our study is those who had a positive test result for SARS in a hospital setting. So either they could have been either inpatient or attending an emergency department, or if there was a death with a primary or contributory cause reported to be COVID-19. By focusing on hospital cases and death, what we wanted to do is limit potential biases, and it's most likely that these cases reflect more severe COVID disease and exclude people who are being tested at the beginning, especially such as healthcare workers who had routine testing. Our exposure of interest was occupational group, as was reported at baseline in the UK Biobank. This just gives you an example of how we've categorized and how we've classified the participants. So employed participants were classified into 5 broad groups. We had non-essential occupational groups, and then we had these 4 different broad occupational groupings. So one group of healthcare workers, social and education workers, other essential workers, and we had police and protective services, which included sanitary workers. To assess whether or not the differences in risk among these occupations within these broad categories, we further classified into 8 more precise categories of essential workers. So we have health professionals, which would be doctors, pharmacists, dentists. Health associate professionals would include nurses, midwives, and paramedics. And medical support staff would be hospital porters, for instance. Social care workers, education workers, food industry workers, transport workers, train drivers, taxi drivers, postal workers, and the police and protective services. In terms of methods, we use Poisson regression models to examine the strength of association between baseline occupational group and risk of severe COVID-19. And we use 6 different nested models going from a first model, which included only socio-demographic factors of age, sex, assessment center, ethnicity, to include socioeconomic factors, work-related factors, number of chronic conditions, lifestyle factors, and fully adjusted, finally a fully adjusted model. Unfortunately, the numbers do not allow us to look at differences by ethnic groups as well. So to examine the potential effect modification by race, what we did is we classified our participants into 4 groupings, and these were white non-essential workers, non-white non-essential workers, white essential workers, and non-white essential workers. So overall, our sample consisted, after applying inclusion and exclusion criteria, our sample was about 120,000 working participants, 29% were essential healthcare workers, and at baseline, women and ethnic minority participants were more likely to be employed in essential occupational groups. Overall, 3,111 participants were tested for the SARS virus in a hospital setting. And from these, 262 had a positive test. 12 of those died. And we also had an additional 9 people died who had not been tested in hospital. So overall, our sample contains 271 severe COVID cases. Looking now at our results, looking at the risk of severe COVID by broad essential occupational groups, what we see is that in comparison to non-essential workers, healthcare workers had more than a 7-fold greater risk of severe COVID. And this association remained after adjusting for all covariates. Social and education workers also exhibited a higher risk, which also remained after adjustment. All other essential workers had a slightly higher risk compared to non-essential workers, but this was attenuated when we adjusted for lifestyle workplace factors. Overall, men, those of South Asian and Black ethnic groups, those socioeconomically disadvantaged and the least educated groups had a higher risk of severe COVID-19. When we looked at work-related factors, shift work and manual working was also associated with an increased risk of COVID-19, as were being overweight or obese and being a previous smoker has been reported in previous studies. When we look at the more detailed occupational groups, by breaking down the previous into the 8 categories, what we see is that relative to non-essential workers, the medical support staff, so hospital porters, for instance, had the highest risk of severe COVID-19, and this was followed by health associate professionals, so nurses, midwives, paramedics, for instance, and then healthcare professionals. The higher risk of severe COVID-19 among these healthcare workers was not reduced, as you can see, after adjustment. For social care workers, the risk was also elevated, and it was only slightly attenuated for the different covariates. And the other group for which we saw higher risk of COVID-19 was transport workers, which exhibited about a 2-fold higher risk of severe COVID compared to non-essential workers, but this was attenuated after adjustment. For the other occupational groupings, we don't see any strong associations compared to non-essential workers. In our post-hoc analysis examining the potential effect of modification by race, what we found is that the risk of severe COVID was the highest in the non-white essential worker group, which you can see at the bottom. And this occupational group had more than an 8-fold risk compared to non-essential workers who are white. The risk of severe COVID in non-white, non-essential workers and white essential workers were very similar, which further suggests effect modification by race. Accounting for all different socioeconomic, work-related, and lifestyle factors did not substantially attenuate the results. So the comparisons of severe COVID-19 across occupational groups has highlighted how these higher risks seem to be particularly linked to the jobs themselves rather than reflecting broader socioeconomic circumstances. Obviously, there are limitations associated with the data and the representatives of the sample, but what we found was that healthcare workers had more than a 7-fold higher risk of severe COVID, and those in social care and transport occupations had a 2-fold higher risk, and that non-white essential workers had the highest risk of severe COVID infections. We think that our findings reinforce the need for adequate health and safety. In terms of implications, our findings reinforce the need for adequate health and safety arrangements and provision of personal protective equipment to reduce exposure and limit spread of this COVID in the workplace. Intervention should be implemented and delivered, especially as other occupational groups are now returning back to their workplaces and social distancing measures are being relaxed. And it's also clear that obviously testing should continue for essential worker groups, but there's probably also a need to extend this to wider and more disadvantaged occupational groups. Just to finish off, I'd like to thank all our co-authors, and especially Miriam Mutambutsi and Claire Nidwich, who both led on the paper for this. So thank you very much.
Hey everyone, I'm sorry. I'm going to present about a study that we've finished probably a couple of months ago now, but isn't going to involve any of the kind of fancy stats that that Mike presented to you. So it's going to be a bit simpler, probably. We were interested in understanding a bit about the mental health and health-related, how mental health and health-related behaviours changed during the COVID lockdown. So just to recap, as I'm sure you all remember, early on during the pandemic, there was very large-scale social changes, and there were concerns that some of these large-scale social changes could themselves have impacts on health. And in the short term, particularly things like mental health, but also health-related behaviours. We were also particularly interested in whether different population subgroups might be impacted in different ways. So this work is available in a preprint that's listed there, and just to emphasize that actually most of the work was done by other people. To recap, there was a period of time, largely in March, where different lockdown measures were incrementally implemented. But then after that, in April, generally the lockdown kind of remained pretty much unchanged throughout April and applied across the whole of the UK. So to look at this, we analysed a well-known large data set called Understanding Society, also sometimes referred to as the UK Household Longitudinal Study. So this is a representative survey-based study which collects information from a random sample of UK households. Historically, it used to be face-to-face. More recently, it's been a mix of face-to-face and online, and during COVID, it's been pretty much exclusively online. And the way it works is people get interviewed every year, but the way data collection is organized is it's collected over a roughly 2-year period, with the most recent pre-pandemic data covering the 2017 to 2019 period. And then as the pandemic started, the organizers of Understanding Society decided to collect data towards the end of April, and since then they've carried on with roughly monthly data collection as well. And they're collecting information on a range of variables, but includes things like assessments of mental health using a well-known scale, the General Household Questionnaire, which you can use to define people as experiencing psychological distress or not, and also loneliness as well, which Mike mentioned before. And as well as that, there was also information about whether people were smoking, how much they were smoking, drinking, and so forth. So what we did was we just tried to figure out what the prevalence is, so how common were these different experiences and behaviours in the population and across different population subgroups. We also did some more longitudinal regression type modelling, but to be honest, the results are pretty much the same. So I'll focus on showing you the simpler stuff. Just to give you a sense of the numbers, don't worry about the detail here, but you can see that we've got information from wave 7, 8, 9, and then the first COVID wave. And we've got roughly 25,000 odd people in each of the waves before COVID, and about 11,000 people during the COVID wave that we were analysing data from. So what did we find? Well, so we've got a graph here that shows before the pandemic in the kind of pink colour, and after the or during the early phase of lockdown rather, so in late April, in the light blue. So the first couple of columns is the mental health measure, the psychological distress measure, and you can see that the prevalence of GHQ caseness, so this measure of psychological distress, really shot up. So that's, I've done a few studies now where we've looked at this measure, and that's a far bigger increase than we've seen with other things like the Great Recession and things like that. You can also see that some of the alcohol measures have changed quite a bit. So in the third set of columns shows binge drinking, so that's these ones here, and you can see that the prevalence jumped up for binge drinking at least weekly, but in contrast to that, how often people were drinking fell. So it's, sorry, how many drinks people were drinking on a typical day fell rather. So it's a bit of a more mixed picture in terms of drinking, and in terms of smoking, you can see there's been a fall in people who were active smokers as well. When we drill down into the mental health elements, one of the things that's quite noticeable is that, so the GHQ-12 scale, it's a very widely used and validated scale, but one of the questions is about being less able to enjoy day-to-day activities, and that really shot up a lot. But then there might be issues about, does that really reflect people's mental health, or is that more just the very fact that they're living in a lockdown means they're less able to enjoy those activities? So we did some sensitivity analyses, and we still find quite a big increase in issues of psychological distress following the start of the pandemic, even if we exclude that item. How about inequalities then? Well, so here you can see some analyses where we split by age, gender, ethnicity, and educational attainment. And one of the kind of more striking things is that it seems to be that young people in particular were affected in terms of their mental health. So were women, and to some extent also Asian ethnic groups. So I've tried to give you a very rough overview of what the paper found. You can go off and read it if you'd like, with the reference there. We are planning on doing some further work, hopefully looking at how these trends evolve during the ongoing pandemic, looking in a bit more detail about which particular groups are being affected, and are they being affected more so than we might expect, and also trying to actually unpick what are the pathways that might explain any changes in inequalities. And lastly, as Alistair mentioned, we're doing some micro-simulation modelling where we're wanting to look at the potential impact of some of the big job losses and income losses that are happening at the moment. So to wind up, so we know that lockdown's been linked to increases in psychological distress, particularly amongst certain groups. On the plus side, though, cigarette smoking fell, but some indications of worsening alcohol consumption, although that's a bit mixed. And hopefully I've tried to give you a flavour of how the data might be quite useful for monitoring and informing policy. So hopefully that still leaves us with a few minutes for questions, but probably not many minutes.
Hi, thanks Patel, and thanks to all of our presenters, so Alistair, Peter, Mike, Leah and Patel, on some really fantastic work that's been done in the Inequalities programme. So as Patel said, we do have a bit of time now for some Q&A. So if anyone's got a question, you could either raise your hand or add it to the Q&A section at the bottom. We did have one question during the session, which was for Peter. So I'm just going to ask it now. So ask Peter whether, you didn't say this explicitly, but is there a key difference between school holidays and the COVID school closures, that parents were meant to be homeschooling during the COVID closures, whilst this isn't really intended during the holidays? So I'll pass that over to Peter. Oh, you're on mute, Peter.
That's a really important point, Danny, and it is one that I did try to cover in the last couple of slides. I said that school closures were differed from school holidays in the sense that schooling continued to some extent, but school closures are similar, or the pandemic-related closures are similar to school holidays in the sense that the experiences of children from more or less affluent households does appear to have differed very widely, though in a different way, to differences during holidays. One of the features of the debate about school closures during the pandemic is that people have been drawing very heavily on previous research about school holidays. The big review that the Education Endowment Foundation carried out was all based on school holiday studies, and all on school holiday studies from outside the UK, and largely on studies of children in primary school, whereas lots of the debate has been about what's happening to older children. So we're adding information about older children, and we're adding evidence from the UK to that, though we do acknowledge that as a very important limitation. Unfortunately, we don't have any direct evidence about what the effect of the pandemic-related closures, or about the differences in support for home learning on children in the UK because of the cancellation of exams during the summer, and it might be some time before we do have any direct evidence of that sort. So I think it is still worthwhile to look at evidence from UK sources based on routine school closures before the pandemic, but thanks for raising that point.
Thank you, Peter. Alison Parks has added a question to the Q&A, and this is for Leah. So Leah asks, is your analysis able to take account of differences in testing of different occupational groups?
Thanks, Alison. I guess I think maybe Alison is referring to sort of the availability of testing for different groups. And that was one of the reasons at the beginning of the lockdown, before we had more community testing, it was more targeted testing to essential occupational groups, and especially to healthcare workers. And for that reason, we tried to mitigate for that risk by just taking hospital cases. So we aren't able to account for differences in testing between the different occupational groups as it is. But in order to try and remove that risk of the differences in different occupational groups, that's why we try to use hospital testing data in deaths as more sort of severe cases.
Thanks, Leah. I can't see if anyone else has a question. Please just raise your hand or add it to the Q&A bar. Although I realise we are quite close to 2 p.m, so we might need to wind this up soon. But I did have a question myself for Mike, which was the in-person contact that seemed quite important in your findings. Did you have any idea of the frequency or type of in-person contact? Was that asked in the questionnaire?
So they did kind of ask it kind of differently for like contact with children, with other family members and with friends, but we kind of grouped it all together into one measure to do the analysis. There was about sort of 20% or so, with a bit of variation across different groups, who were not getting weekly contact of that type, meeting up in person with either one of their children, other family members or friends.
Okay, thank you very much. Well, we're now at 2 o'clock and I can't see any other questions. So I think it's probably a good time to draw the seminar to an end. And again, thank everybody from the Inequalities program for presenting. It was really fascinating group of questions. So thank you very much. And the session will be available on the SPHSU Hub as a recording. So thank you, everybody. Goodbye.